All right. Well, good morning, everybody. Welcome to the EQUIP subgroup meeting. This is an extra meeting, so we're just giving you your money's worth this month by adding one in. And we just have a lot going on. We wanted to keep everybody updated. So today we're going to continue to talk about shifting to Prometheus and from Prometheus to Paces and how that's going to work. But before we get into that, I wanted to give Melanie a chance to give us a little bit of an update on the MHCC transformation grant. And I believe we still have slots left, but if anybody wants to come in, they're going to have to do it quickly because we want to try to get it finished by July 1. So without further ado, Melanie, you want to give us a little update on where we are on that?
Yeah, thank you so much, Jean. So many of you know me. As Jean mentioned, I'm Melanie Cavalier. I'm the Chief of Innovative Care Delivery at the Maryland Healthcare Commission. So we currently have 24 practices that are in cohort 2 that are getting ready to complete the milestones by June. As you know, you may have heard before, we have a grant that MHCC began in 2021. MedChi CTO provides the practice coaches, and each practice does have a dedicated coach. The program is built on a program developed by CMS when they rolled out MACRA. That program was called the Practice Transformation Network and had over 100,000 providers. MHCC and MedChi were both part of that program. So it's designed to help practices like your practice be successful in value-based care like this program EQUIP. It includes milestones that are assessments, trainings, and redesigning workflows. They're focused on data collection and utilization, collaboration in the medical neighborhood, patient and family engagement, and quality improvement. As Jean mentioned, we do still have spots open, and please contact me or Jean if you're interested. Thank you for the time this morning, Jean.
All right. Well, thank you so much, Melanie. Really appreciate the partnership with the Maryland Healthcare Commission. And this is important work. So today we're going to go over, give a little update on the EQIP primary care materials. We're going to, again, have Nathan talk a little bit about the Prometheus PACE performance differences and some of the episodes. Specifically, we're going to give an update on some of the other specific meetings that we're planning on having going forward. So I did want to note for everybody, if you missed the GI crosswalk, which was, I guess, last week or earlier this week, I don't remember, but it was done. It is up on the website, so you can go up there and you can watch that. And today, right after this meeting, we're having the orthopedic crosswalk to see the difference between the orthopedic episodes. So I think later on, Will or Jessica is going to go through the complete list of the crosswalks between episodes for various specialties that we have scheduled. We're very open to doing whatever education is necessary to make sure everybody understands what's going to happen as we make these changes. So we're going to change it up a little bit, and I'm going to throw it over to Will this time instead of to Jessica, and let Will go ahead and start off and give us a little update on where we are on the EQIP primary care RFI. So Will Henderson, you ready?
Yep, I'm ready.
It's all you,
So
baby.
this will be fairly brief. We have set up a separate series of meetings to take stakeholder input and provide updates on the EQIP primary care program, because we felt like it was probably a different set of stakeholders. As this slide notes, that first one of those is on February 28th at 11, and that is not tentative anymore. That is the confirmed time. And we, I think, Jean, the invite has either already gone out or it will be going out shortly. We're inviting everybody who responded to the RIF, but certainly if you didn't respond to the RIF but you want to be included, you can let us know at this address, hscrc.tcrc.maryland.gov, or you can let Jean's team know, and we'll get you added to that meeting. The meeting on the 28th, we will review the consensus and non-consensus items that we got in the RIF responses and begin to talk about how the state is thinking of moving the program forward. And then we'll have, I think we'll probably have monthly meetings thereafter and keep people focused and abreast of what's going on there as we work towards having some kind of invitation to participate going out probably in late April or early May. So I think that's everything there. I don't know, Jean, if you just want to add, is there where people should reach out to you if they want to be added to this meeting?
I think they can email me, Jessica, or Will, or Olivia Simon at MedChi. If you email any one of us, or if you want, you can even throw your information in the chat or direct message me in this, and I'll figure out how to get you the info. My email address is gransom, RANSOM, at medchi.com, and that's medchi.org. Or medchi.org, sorry. Anyway, so that's it. I will say too, Will, that we actually got quite a few responses to the RFI. I think what was it, like 31 roughly?
25, I think, is the right
25.
number.
Yeah, it was a lot though. So
A
we have a
lot,
lot of
yes.
lot of
Yes.
material to go through and a lot of good helpful input. So hopefully we'll be able to come up with something really good. Is that it, Will?
That's it. Yep.
All right, we'll go back to you, Jessica.
Okay, thank you, everyone. So the next couple slides, we are going to look at some of the high-level differences specifically related to the length of time in like the default Prometheus episodes and those that they map to in the PACES world. Again, I think the intention here is to really get stakeholder feedback. A lot of this is the same, so it would make sense that we just carry through the defaults. There are a couple that we've already either gotten stakeholder feedback that they're that the change within the PACES numbers, isn't something that they would like, or we want to highlight, hey, there's a big difference here. So these are just the PY1 episodes. So keep in mind, most of these are procedure-based episodes. I think there were 2 acute ones, but in majority, all of them typically had a 30-day look back with a 90-day look forward period, so kind of spanning 120 days. However, in Prometheus, the GI episode specifically had a much shorter window, 3 days look back, 14 days look forward. As we look into these episodes for PACES, again, a lot of them are very, very similar. So you have that 90-day period after the episode triggers. PACES calls it a close period. However, for colonoscopy and upper GI, you'll notice that the PACES default kind of mirrors all of the rest of the surgical or procedure-based episodes, 30 and 90. From our some initial conversations with GI folks, as well as the call that we had with the larger group, we do feel that we want to move forward with a recommendation of changing these episode windows to match what they were in the current grouper. So that 3-day look back period and the 14-day look forward period. If there is, again, this is sort of the opportunity to speak up. As a reminder, March is sort of our drop deadline to have everything, the episodes in place, sort of these final parameters and things like that. But want to give this the opportunity for you all to also weigh in. AMI is another one that stands out. Keep in mind our cardiology sort of stakeholder group or specific crosswalk isn't taking place until next week. So we will gain a little bit more feedback there, but that's certainly one that also comes to mind as sort of a larger difference. And we've heard a little bit of stakeholder input, and definitely we'll bring that up and hopefully get some additional feedback on next Tuesday. But anyways, it's here. When we send out the slides, really just want to highlight, now is the opportunity if you really do feel strongly or want more information about some of these differences. Currently, the only 2 that we definitely are recommending a change to are the 2 that are highlighted here, colonoscopy and upper GI, with AMI having that conversation next Tuesday. Moving into the episode 2 categories. So you have now a lot of our chronic type of episodes, SRF or your complication episodes. Again, overall, it's somewhat mirrors. Our chronic ones are basically the same. There's a 30-day look back period, and they end when the performance period ends. So pretty straightforward there. Cataract surgery has a difference, and some of these other complication episodes, you kind of notice that PACES has a 90-day window for all of these versus the 30, which was the default in Prometheus. Overall, you'll kind of see some of the information that we will be sharing in some of our other groups, but we don't really believe that there's much of a difference there. Again, this is the opportunity for stakeholder feedback. But certainly something that we can take into consideration as you guys take a chance and look at this or want any more information. So we're all paused there. Obviously, you guys will get the slides, but if there is any initial sort of feedback or things like that, now's the time to speak, or feel free to email us directly to kind of engage in that conversation. Okay. Hearing none. So I'm going to hand it over to Nate, but essentially one of the things that we've done is, well, we've done a lot of modeling. Our colleagues at H-Metrics have been really great in sort of helping support a lot of the questions that have come in on this. And one of the things that we really wanted to look at was essentially overall, if the exact same participants, participate in the exact same episodes, what would it sort of look like? What is the net roll up? Are we seeing the same around 5% savings that we saw in the first year, and sort of things like that? So I'm going to turn it over to Nate. He's going to kind of talk about this because it's not, of course, a direct answer. There's a couple of considerations and a lot of the conversation that we're having over this next month when we talk about exactly what PACES looks like, some inclusion, exclusion things that we can decide. It kind of factors into this larger picture. Overall, I think the state feels pretty confident that we're seeing similar results. Again, there are differences that we have been highlighting, but certainly something that looks good sort of from a high level overall. Nate, you want to review this slide?
Sure. So essentially, again, as Jessica said, what we're really trying to do is just test and then document the impacts of the transition on the program and understand what we're likely to see in future program years based on modeling out what it would have happened in the first performance year of EQIP, given that that's the only year at this point that we do have complete performance data for. As we've discussed, there are some differences in the way that PACES and Prometheus roll in sequelae or related procedures, diagnoses, and services. And so this slide just kind of highlights three different approaches that we've discussed. The top set of tables is just the base episodes only. This is probably the furthest from matching the current program, just using kind of the named core episodes. The second or middle table shows the impact if you include combination episodes, which is a fairly significant piece of PACES, basically the way that they recombine related and temporally close procedures or conditions occurring. And the last one, which is currently the one that seems to best represent from a resource and clinical standpoint, what we're trying to achieve using the Prometheus grouper, is including all of the combinations and sequelae associated with the target episode. And we can talk a little bit more about what that means. But essentially, the intent of this was just to understand how these different approaches related to the minimum savings threshold and performance under the program, and make sure that there weren't huge variation between the results that we saw under Prometheus and the results that we would have seen under PACES. Now, you'll note that there are some differences that do exist between the total savings and the number of entities that fall into each of these categories. I will note that while some differences are expected, to a degree, the numbers in this table also reflect episodes that require a bit more nuanced mapping. The one that we'll be talking about later today that is undergoing revision by PACES right now are the spinal procedures. We know that there's a pretty big difference in how those episodes are categorized, and ultimately that will just come down to guidance from the state in terms of mapping your enrollment, if you're involved in one of those episodes, from the Prometheus episodes into the PACES ones. But for the purpose of this slide, we did a fairly straightforward mapping between the two, and so the differences between those episodes is going to impact the savings numbers, which is why you see some of the differences here. But overall, again, our goal was just to ensure that we weren't seeing huge shifts in the numbers of entities that were successful in demonstrating savings or hitting or missing the MSR. And this is just to facilitate kind of public documentation of those results and something to build on as we move forward and continue discussions with participants to make sure that we're comfortable with the policy decisions that are made in implementing PACES as a potential replacement for Prometheus.
So this slide has a lot of information. I think, as Nate mentioned, overall, it looks pretty good. One of the things that I think will stand out when we look at individual entities is you have some entities that were borderline meeting the MSR and also vice versa, just barely missed it. And those are probably ones that you're going to see a little bit more movement on because it was very, very close, essentially, to begin with. But again, these overall numbers really look kind of the same. They look good. There's going to be nuances in between that. But I think that gives the state at least confidence that this isn't such a drastic change that things that were successful implementations for our current participants are not going to be are not going to show results for this new group. So. And then lastly, Nate is going to essentially, when we have these conversations with our specialty groups, we are going to be passing along sort of a more rough version of a playbook. We will produce before the end of the year sort of this nice clean PDF that you guys are used to with the Prometheus. But there's some different definitions in here, and we really wanted to spend some time just to review when you get a playbook or you're seeing some of these words, what does that mean? What things should I pay attention to? A lot of times people are really looking at just kind of the initial triggers and kind of getting a sense there, but are sort of these associations and sequelae that PACES has. How do they play into this? So I'll hand it back to Nate, but he's going to review some of the definitions of this workbook, but also will share what an actual workbook looks like to give you guys some background on what you may see, and again, how you can sort of approach the tons of codes that you're going to be seeing that will give you to kind of make some assessments and things like that. Nate, did you want to share or did you want to review this slide first?
Let's review this slide first. And again, a big goal of this transition is increased transparency and hopefully facilitation of understanding of what exactly goes into these different episodes. There is a complete business rules document that has a lot more information that we can make available. But this is essentially a Cliff Notes version, just to get it out in front of everyone so that as you start reviewing the episode definition workbooks, you have something that's relatively quick and simple to refer to. Some of the terms, like Jessica mentioned earlier, are slightly different between PACES and Prometheus. So things like close period, look back, versus total episode length. I think we'll just need to make sure that we're really clear when we're talking about the new episode definitions, which data elements we're referring to. And so that's why those are included here. The main pieces that I did want to call out, just because I know they'll cause questions if we don't otherwise, are any place where you see a rule or rule ID of some sort. So like the fourth entry here. Those are just designations that will appear in the definition workbook that map back to tables in the full documentation we'll make available. So in the context of the definition workbook itself, that data element may not make a lot of sense if you see, Rule 104. But the answer to that is we can get into the full documentation and in things like the episode rule, determine how exactly an episode gets put together and how episode identification takes place. And that additional information is just a bit much to put into these episode definition workbooks, especially since from the discussions that we've had so far, the main interest is really looking at the trigger codes, the relevant diagnosis codes, and the associations. And all of those you can pull out of these workbooks without necessarily having to get into the more granular details around the rules and the closing identification logic, though again, that will be made available. So did want to highlight that. The second piece is, though these definition workbooks do include relevant RX or drug codes, we don't currently receive program data that would be required to fully include those. So same as past policy, these relevant RX aren't currently included, though we are looking to hopefully be able to include those in the future if it's something of interest. But in that regard, the PACES episodes will be the same as Prometheus. We're not including or excluding any data there, but we have included them here since they are part of the definition. So once those are available, we could avail ourselves of them. The last piece is just a note about associations. Again, we do include episode associations in the definition workbook, so you can get an idea of what the direct sequelae and indications for the episode definition are. But like with the some of the parameters like rule and close ID, it does, to get a full understanding of those associations does require looking a bit more at the business logic. So you will see some fairly straightforward associations like the examples here, where you'll have, you know, a parent episode of knee replacement and a association with a child episode of sepsis. And likewise, you'll see relatively straightforward indications, you know, osteoarthritis to knee replacement. Looking through the definition workbooks, there are some associations that at face value look a little bit more confusing. And the answer for that is, again, just there's a lot of logic under the hood that goes in determining which associations are actually pulled into an episode and how those relationships are established. And we can always go through that in more detail in the future. And the business logic rules do provide a pretty good explanation of how those work. But again, the goal of this exercise right here is just to get those definition workbooks out in front of folks sooner rather than later, with the understanding that more information will be coming as we get further and further down the road. So with that, Jessica, I think I can pull up an example just to give everyone something a bit more concrete to look at. So the definition workbooks right now, the way that we've created them, since there are over 1,000 episodes, we want to be able to create and update these in an efficient fashion, are just Excel workbooks. There is one Excel workbook per episode. And right now we're focusing on making the definition workbooks for the episodes under consideration for performance year 1 and 2 available. Obviously, if there are other episodes of interest that we need to discuss, we can circulate those as well. But do know that we do have workbooks available for all 1,000 episodes, regardless of finalization status. We just don't want to overwhelm folks with more information than is needed. When you open the definition workbook up on the left-hand side here, you'll have the basic episode parameters. Each piece's episode is identified by a unique ID that will typically start with a 2-letter code. TP indicates a procedural episode, and then a 4 numeric code for the unique episode. As I mentioned, you'll see some of these data elements like rule 104 just has to do with how this particular type of procedural episode is triggered and established. And then again, close ID is just a numeric indicator of how this episode terminates and closes out. But you'll see basic parameters over here. These may expand over time as we go into additional episode categories. But for the most part, these parameters will be pretty standard and establish the baseline structure of the episode. And then off to the right-hand side, you'll see separate columns. Each of these are going to contain information on a different aspect of the episode. So in this case, the first section will contain the trigger codes. These are the codes that can potentially trigger an episode based on the associated diagnoses and services that are indicated in the claims data. Each section will include a nomen or nomenclature that's used to designate the code. And the one thing I will call out here is that you will see a mix of CPT and HCPCS codes if for the nomen of CPT. So if you see an alphanumeric code here, it's just consolidation for simplicity's sake. We may update that in the future to make it easier to pull out the CPT versus HCPCS codes, but just a heads up as to that small idiosyncrasy in the way that the nomenclature is called out here. Relevant diagnoses are probably going to be the longest category, similar to the definitions under Prometheus. There's potentially a lot of different relevant diagnoses that can play into a procedure or condition. These are almost universally going to be ICD-10 codes because that's the world we live in right now. But it does give the full enumeration of these different codes. For condition episodes, typically, you may see relevant procedures. For a lot of episodes, these are still either under development or not applicable under the current logic. So you will see a none populated here. If it isn't currently populated here, we're looking at a procedural episode. So we're primarily interested in looking at the relevant diagnoses. And it is worth noting that just because there are no relevant procedures under that definition of the way that the PACES uses that nomenclature, you may see other treatment episodes as associations over here. And those are how those might get linked into this episode during construction. Again, the relevant RX section is just included for reference here. For the most part, we are not using those, but where those have been established in the definition, they'll be listed out. And the last section here is the direct episode associations, where you can see the different types of associations that source from this particular episode. These are typically going to be broken into indications for procedural episodes as to why you might conduct that procedure, as well as sequelae, which could be avoidable events. They could be unavoidable events. It's just a mixture of different conditions that could arise that would be relevant to pull into that episode's clinical and cost profile. If there are any questions about the workbooks as folks start reviewing them, please do reach out. If there aren't any answers, if there are any questions that we're not able to answer, the PACES team is very accessible, and we're happy to work with them to make sure that everybody has a clear understanding of the information that's being provided. With that, I will pass it back to you, Jessica. I think we have a couple of more slides to go through before we close out.
Yep, thanks, Nate. You guys can now see my screen again. So with all that information, we just kind of want to remind people or just where we are on this decision point timeline. So we introduced PACES back, I think, in actually November, spent a lot of time doing some initial analysis and presented a high level sort of crosswalk at the January meeting. Our focus really over the last 2 months, well, this month and next month, has been doing these more detailed level analysis, giving information to you all as a requested, because we really want everyone to feel comfortable with sort of this decision, knowing that it's going to be a big change. As mentioned, during this time frame, that's really where the stakeholder feedback, if there's concerns, considerations, where this needs to occur, because March is sort of, in our mind, at the March meeting, which I think is the 15th of March, sort of our deadline, our internal deadline to have all of the episodes, these sort of parameters, most of that decided, because there's a couple things that have to happen before July when our enrollment period enters. Obviously, if there are changes, there's maybe some initial analysis, there's approval with CMMI, and then we want to ensure that we're recruiting and bringing new people onto the program, but feel confident that we know exactly what episodes and the construction of things. So we sort of need to have that fine-tuned before we can, reach out and hopefully bring more people into that. So we did have our GI meeting, as Jean mentioned, last week. And just following this meeting, so at 10, we're going to do a deep dive in the orthopedic episodes, a crosswalk of what they look like in PACES. And then we have 2 additional ones, one each week. So cardiology and neurology, these are evening ones. Again, we're trying to hopefully have it at a time where people can attend. We know clinical input is really important in sort of making some of these decisions. So certainly want to hopefully have some attendance with like our lead care partners and areas. So we have a cardiology and neurology subspecialty meeting each Tuesdays following each other from 6 to 7. And then Jean mentioned if there is interest from a larger stakeholder group, please let us know. We're happy to host other things. A lot of the other ones seem fairly straightforward, but again, stakeholder feedback is vital here. And then finally, that next meeting, the March 15th meeting, that's the big one. We're going to kind of come and present all these decisions to you guys, and hope you all can join that. So I think that's it that we have for today. I did see something pop up in the chat. Oh, Jean sent information about the primary care RFI information in the chat. So please click on that. And all of these will be posted. MedKai does an amazing job recording these and putting them on the website. Chris is a little bit slower, but they're on our website as well. But please attend. Again, we really want your all's feedback. So.
Does anybody have any questions about the upcoming webinars, how to sign up for the RFI, concerns about any of the other PACEs? The one other thing I did want to mention is the other thing that Jessica and Will and Krista and I are working on is adding additional episodes. We haven't forgotten that. We are really getting, though, to where if you don't talk to us soon, it's not going to happen. So I would just ask if anybody has a burning desire to add something, they've got to communicate with us now. And particularly, we are working very hard on not only working on figuring out how we're going to do the primary care thing, we are having meetings on behavioral health and taking what the work that Nate and his team at PACES have done and kind of finalizing that. And we've had discussions around other PACES episodes that aren't fully completed. But if there's something you're interested in doing, we really need to have a discussion like yesterday. So that would be the last point I would make, unless there are any questions. All right, well, everybody have an enjoyable rest of your day. And for those of you who are really energized and want more EQIP, at 10 o'clock, we're going to do the ortho crosswalk. So you can see Nate, Jessica, and I again in just 30 minutes.
Thank you, everyone.
Thanks.